So today, presenting for us is Heiko. Heiko is the Director of Digital Solutions at D-Tree International. He has more than 2 decades of experience in human-computer interaction, software development, and information systems design. Heiko leads D-Tree's digital division and provides technical leadership and guidance to D-Tree on human-centered design, requirements, development, and quality assurance. He liaises with governments, technology, and research partners to ensure that D-Tree uses the most appropriate technology in its programs and uses data strategically to assess program outcomes and feed insights back into program design. He has a PhD and master's degree in computer science from the University of Campinas in Brazil, and a master's in business informatics and from Darmstadt University of Technology in Germany. So Heiko, I will pass it over to you now to begin your presentation.
Thanks for the introduction, Chase.
You're welcome.
Welcome everybody to this session. The title of our session now is Towards Tailored Perinatal Health in Zanzibar Through Machine Learning. And as Chase said, we are going to go through design issues, design questions that arise in a machine learning enabled frontline health intervention and try to understand some of the limitations, possibilities, and risks and chances that we face in this context. We will do this with on the example of an actual community health program that D-Tree is implementing together with the revolutionary government of Zanzibar. And yeah, to start us off, I will give you a brief overview of this community health program and a quick high-level, non-technical overview of what machine learning actually is. I will then present how we approach tailored care pathways for perinatal community health services in this program. And we'll then lead on with a discussion of program design trade-offs that we faced when we set up this program. And then after my presentation, we have some time for discussion and Q&A. So to start us off, let me give you a very brief high-level introduction of the Zanzibar Community Health Program to make all the issues and topics that I'll discuss in this session a little bit more real and applied. First, some geographic context. Zanzibar is a semi-autonomous region of Tanzania, a country in East Africa. Zanzibar consists of 2 main islands and a couple of smaller islands off the coast of Dar es Salaam, the economic capital of Tanzania. D-Tree International has been active in Zanzibar for a little bit more than a decade and always in the community health space. And challenges that we faced there when we started our work include a fragmented delivery of community health services, low access to quality information at the household level, and community health volunteers with limited education and skills. And these were also challenges that the government recognized throughout the years. And so some years ago, they tasked D-Tree and other development and implementing partners with supporting them in building a national community health program. The goal of that program was to create better coordination and cohesion of all community health services. At the time, there were many implementing partners with programs and even vertical Ministry of Health programs that were not coordinated so well, and make sure that community health services can be delivered in a high quality using a comprehensive digital platform. So before that, most, if not all, community health services were delivered paper-based. And high quality here means in a sustainable, equitable, effective, and efficient way. And a third goal relevant to this session was to make data available for decision-making. So if we look at these goals, data availability, effectiveness, efficiency, digital platform, these are all themes that are already very well connected to an intervention that is evidence-based and data-based and can really favor a data-based and machine learning-based approach. So about 3 years ago, we started then to set up this national digital community health program. And the program works on 3 different layers of the health system. And it establishes digital coordination through digital tools that are used for work planning, decision-making, as job aids, and also for decision support at the different levels of the system. So at the lowest level of the system, we have community health volunteers who deliver health services at household levels in the communities, and they use a digital app that is based on the community health toolkit by Medic. And the services that they deliver generate data that is then used by CHV supervisors and further up the health system by local government and central government to conduct real-time or near real-time data analytics and to use this data for short-term and long-term health system decision-making, including policy changes like budget allocation, but also including conduction of short-term health interventions. So this is a very brief overview of the National Community Health Program. Most of this, well, I would say, yeah, most of this to date is working without machine learning. And then a year ago, we looked into some opportunities to introduce machine learning for some health services. So before I describe this added service, I want to give you all a very brief introduction into what actually is machine learning. So in very general terms, machine learning is the science of getting computers to do something without programming them explicitly. Or in other words, it's a technique that enables a computer to automatically identify patterns in a data set without giving the computer explicit instructions about what to look for. If you contrast this to human or manual data analytics, if you use a machine learning enabled approach, the amount of human intervention or human work is much lower as compared to a machine learning approach. And the approach is also different. If you do manual or human data analytics, you usually have a very clear analytics goal, while machine learning tries to identify patterns that a human analyst might not be able to detect. So machine learning is specifically valuable when the data set that needs to be analyzed or the data set that you have is very large and very complex and contains, for example, a large number of different variables that are too large to be analyzed by traditional data analytics tools. So this is machine learning in general. Now, there's also predictive modeling with machine learning. And that is only one type of machine learning. And it's currently a type that D3 International is looking into in our programs. Predictive modeling involves developing a model that can predict the chosen target outcome from input data that we provide. For example, the target outcome, and this is exactly what we are doing in the intervention that I will talk more about in a few minutes. The target outcome could be whether a woman will have a successful delivery. So that is a basic yes or no question. And the result of that question will tell us whether that woman might benefit from receiving special services to improve her chances of actually having a successful delivery. So if the answer to the question successful delivery, yes or no, would be yes, we will say that that woman likely doesn't need any special intervention. But if the answer is no, that would tell us, oh, there's a high risk of that woman experiencing perinatal child death or other complications during delivery. So is there something that to to turn the odds and make the delivery successful. And the prediction, I said it depends on the input data, but that's rather abstract. So in practice, the prediction would be based on input information about her health, for example, previous pregnancies or other historic health data of that woman. But it would also include socioeconomic circumstances and potentially even other data points that we can directly associate with the woman. Now, if we would conduct traditional manual data analytics, if we include other data points, we would potentially not know what would be the impact of these data points on the pregnancy outcome. But that's exactly where machine learning makes a contribution, because machine learning can then be used to detect these patterns that would normally go unnoticed and then indicate whether these patterns can have some relevancy on the delivery outcome in this case. Of course, as with any technique or with any type of intervention, there are also limitations. And as machine learning is still fairly new, although it is getting more mature, I think it's very important to talk about these limitations. So first of all, we have a technique called predictive modeling, but we cannot actually predict perinatal child deaths or any other outcome if we apply this to mostly any real world setting. What we can do is we can estimate a higher risk. So real world settings are just too complex. There are too many unknowns, too many factors, so that we cannot predict things. There's just too many things that are out of our control. And also, since real world settings are so complex, our predictive model can never be perfect. We always have false positives and false negatives. So in our case, for example, a false positive would mean that we predict a perinatal death, but actually the delivery is successful. And on the other hand, a false negative is when we predict a successful delivery, but actually a perinatal death occurs. And furthermore, a higher risk does not necessarily mean that the pregnancy outcome will be negative or that the child death will occur, and vice versa. So this is one of the big limitations of predictive modeling, be that through machine learning or be that through traditional statistic methods. Another limitation is that machine learning shows correlation but not causation. So our model would show us who is likely to be at risk or at higher risk of a negative outcome, but it would not tell us why that might be the case. So then if we don't have the information about the why, how can we respond if an estimated higher, how can we respond to an estimated higher risk of perinatal death? And that is a question I'll try to shed a bit more light on in the next few minutes or so. So how can we address these limitations? And I only show two of the big topics of limitations of predictive modeling. Let's start with false positives and negatives. First of all, in practice, it's impossible to eliminate false positives and false negatives. And it's also difficult to reduce those through modeling. And often if we reduce one, for example, the false positives, in practice, often the other increases. So that's really a difficult issue. So we need to accept that we always have to work with false positives and negatives, and we need to conduct a risk analysis and an impact analysis of the impact of these false positives and negatives and how we might mitigate this impact. Regarding the missing information about causation of reasons for higher risk, our approach is that we try to couple machine learning with health expertise and with public health expertise. And I would also say this is usually a good idea in any problem domain. You should never just blindly trust a machine learning model. You should always question predictions or model outcomes and try to make sense of these with domain expertise. And this coupling of statistical knowledge and health knowledge and technology knowledge and this coupling with intervention knowledge, this is where the human-centered design approach comes in. So this is usually where you want to work together with domain experts, with public health experts in our case, and with health experts, but also with technology experts and with the machine learning experts to make sure that the intervention you design actually does something responsible and factors in all the potential anticipated or unanticipated outcomes. So that was a brief primer about machine learning. Now I want to give you a brief overview of what we did in Zanzibar and the machine learning enabled intervention that we added to the community health program here in Zanzibar. So first of all, what was our motivation to do this? In Zanzibar, as in many other places, neonatal mortality continues to be a challenge. The numbers of neonatal mortality, the ratios are still higher than what we want to achieve, for example, as postulated by the Sustainable Development Goals, and also according to the targets of the Zanzibar Ministry of Health. On the other hand, community health volunteers and the health system in general has to work with very limited resources. So it's very difficult to design a health intervention that, for example, follows a blanket approach and just tries to increase service level for all clients. It's just not possible because of the resource constraints. So that's the situation. But then, on the other hand, if we were able to assess which pregnancies have a high risk of perinatal mortality, this would enable us, or this would enable CHVs, to provide tailored services to these women or to the women who need it most, and through that way create efficiencies and effectiveness, and through that way reduce perinatal death overall from the public health perspective. And then, of course, the great appeal here is that we could use resources more efficiently and effectively if we really have a strong model and if we can really use this model to design a strong intervention. So that's the Zanzibar context, but also it's an interesting challenge for the global health field because creating and implementing predictive models for reducing perinatal mortality has been difficult in the sector, often due to poor data availability, but also due to other factors. So by doing the work that we do in Zanzibar, we also hope that we can contribute to the global health field in general. So what we did in Zanzibar, putting all together the machine learning overview that we heard, the health challenges that we face, and then the existing community health program supported by a digital platform. What we did was, with data from a previous program, we created a predictive model to predict a higher risk of perinatal childbirth, and then used this information together with manual assessments and with health expertise to enable CHVs to provide tailored care to pregnant women. Now let's pause a moment and dissect that phrase. So we used data from a previous program. So we used historic data from a program that D3 implemented before that national community program. But it's also a program that was implemented in Zanzibar together with the government, just not at national comprehensive scale. So we had local data and we had quality data, which is one of the most important prerequisites to do anything with machine learning. You need good data. And this data spanned almost 5 years and included about 50,000 pregnancies with delivery outcomes. So in order to create a machine learning model, you also need your outcome variable, and we had around 50,000 pregnancies with outcomes, with deliveries, with positive and negative outcomes in this data set. The data set spanned around 140 variables. So in order to manually analyze these for patterns and for correlations, you can imagine that this is already beyond the capacity of a human analyst. So we collaborated with NLab, the Center of Excellence for Machine Learning Supported Social Policy and Decision Making at the University of Nottingham, to create a machine learning model. And they actually created this first model for us, but with our input. So they had the machine learning expertise, and we brought the health expertise, the public health expertise, as well as the community health and implementation expertise. And then we try to use the outcomes of this model to provide tailored care. And tailored care here really means taking first steps and being really humble and being aware of all the decisions. And the way we interpreted this and the way we thought was feasible and responsible with the model that we had and with the other resources that we had. The way here is we want to enable CHVs to discuss risk factors with pregnant women, and not only general risk factors, but risk factors that apply most to these pregnant women, and then discuss with them how to mitigate the risk factors. So how does it work in practice? I mentioned that we are leveraging our digital community health program, where CHVs use an app as a job aid and as a work planning tool. So CHVs identify pregnant women in their community and then enroll them using a digital app, conducting a manual risk assessment, and that manual risk assessment collects data points that are important for the machine learning model. Upon finishing this visit, the Jamini Afia app conducts a model-based risk assessment. So the machine learning model runs on the CHV app. It runs offline, it doesn't need an internet connection, and then it does this risk assessment in the background. It doesn't actually communicate the outcome of the risk assessment to the CHV. This was a design decision. We could do it, but we chose to not do it. And then based on this risk assessment, the model-based risk assessment and the manual risk assessment, the CHV then starts to provide tailored care in follow-up visits. So that's what we are doing. And when we designed the program, we had to make a number of design trade-off decisions. And in the last minutes of this session, I want to go through some of those and just want to provide some pointers where I think we should usually look at when we design this kind of intervention. So with any public health or health intervention, we should follow the do no harm vaccine. This is no different for machine learning or any other intervention. However, for machine learning interventions, since it is still a relatively new approach, I think it's worth looking into where the harm actually might be introduced. And what we are seeing is there are three levels of where we could introduce harm. One level is the data level, and here we have topics like privacy and bias. We could, for example, reveal personally identifiable information and expose clients or pregnant women in this case. Or we could introduce a bias that could disadvantage certain people, for example, by not providing relevant services, or by not providing services at all, or by providing services that might be harmful for a certain population. Privacy and bias are already topics that are getting more and more well established and more well understood. And there's already lots of resources out there, so I won't talk too much about these issues. And then the other two levels are at the level of the predictive model and at the level of the application. And here we need to look into quality metrics of the predictive model, but also not look at these in isolation, but try to look at these together with the application or the intervention that we are designing. And then looking at the application or intervention, we also need to look at what is the potential power and potential impact of the intervention, both positive and negative, and both anticipated but also unanticipated. And how does this play together with the model or the different options of the model that we have and that we can choose from. And in the last years, we have seen that more and more organizations have begun to formulate and apply principles of responsible machine learning to promote ethical, transparent, and accountable practices. So a few years ago, there was a Wild West, El Dorado kind of attitude where you would just do things and explore things, and then people try to realize, oh wait, the stuff that we're doing can actually introduce harm. And now the field, I think, is shifting to being more responsible, and there's lots of great resources out there. I won't go into details there, but it's fairly easy to find them. But even with these resources and with a principled approach, there are still many trade-off decisions, and there's not really a cookbook or a checklist that you can follow. So you really need to be mindful and apply human-centered design, introducing different perspectives and different stakeholders to make these trade-off decisions. And on the next few slides, I'll touch on some of these that we faced in our program. So looking at the predictive model, I already mentioned false positives and false negatives. And there's also a third topic, which includes the quality metrics, as for example, accuracy of the model. So false positives, in our case, a false positive is a woman with a regular risk that is classified as high risk. So for this case, if you have an intervention that, for example, actively communicates to the client, oh, you're at high risk, this might then actually tell that woman, oh, you're at high risk, while it's actually not the case. And so it might create anxiety and fear and other emotional distress, and then effectively increase her risk, or maybe introduce a risk that wasn't even there. So this is an example where you need to be really, really careful with an intervention. A false negative, on the other hand, would be where you classified a woman with a higher risk or with an estimated higher risk as regular risk. And that means that the woman might be deprived of a service that could lower her risk. This could be through the intervention, or it could also be accidentally when, for example, CHVs would prioritize high-risk clients and then don't have enough time to provide services to regular risk clients. And then accuracy or other metrics is also something where decision makers that are not so versed in machine learning could just look at the numbers but could predict them incorrectly. So for example, accuracy is a proportion of correct predictions as compared to the total number of cases, in this case, negative pregnancy outcomes. And if a negative pregnancy outcome is a rare event, then your model can have a high accuracy but still miss many of these negative outcomes. So that's one example where you have to be really careful. Machine learning or data scientists Machine learning experts, they know this, but sometimes if there's not good communication to the subject matter experts, this is something that can be overlooked. So reiterating, you need to, it's really difficult to tune these or to have the optimal method or model. So you really need to just accept that this is a case. These these issues are a reality, and you need to work with them. So the approach that we took here was we considered the interdependency of the model optimization and the intervention design. And we acknowledge that you cannot talk about one without talking about the other. And the second approach was we follow a health system informed core principles. And these the three main principles that we introduced were: we say that women with a regular risk, they must not experience a decrease in service delivery. So we don't want CHVs to jump on the high-risk cases all of a sudden and then neglecting the low-risk cases. And we also don't want the situation where high-risk clients get so we want the high-risk clients to get tailored services that reduce their risk. And whatever we do, we need to consider the impact of false positives and negatives to reduce the impact of anticipated and unanticipated outcomes. I'm aware that I'm running slightly over, but I'm finished in a couple of minutes. So how did we treat these trade-offs of model optimization and intervention design? So our first step was to create a wide range of different models using different machine learning techniques. And as I mentioned, our partner NLab helped us and created these models with us. And when we looked at the models, it became clear that any model that we choose would have a limited overall accuracy and a considerable number of false positives and negatives. We were fairly comfortable with the ratio of the negative pregnancy outcomes that could be predicted, but we knew that we would have to work with this. And this is also remembering that predicting perinatal child death is a hard problem in the field. So it's still really challenging to create a model that really ticks all the boxes or really has high metrics in all categories. So when we realized this, we opted to be very conservative in designing the intervention because it really is something new. It is something that is not yet well understood in public health, and specifically with our government partners and with our Ministry of Health partners, both in the public health and in the maternal and child health space. So we were really aware of this and tried to play it safe. And we decided that we will provide additional health education to our maternal health clients that CHVs would provide. But we opted for CHVs not communicating personal risk status to the pregnant woman. And we also thought that as the intervention that we designed is unlikely to increase the risk of any participant, we opted for a model that reduced false negatives so that we don't miss out on potential negative child outcome, delivery outcomes at the expense of increasing false positives. So we actually delivered too many services, but to be able to miss out on as few negative outcomes as possible. So in the interest of time, I will go a little bit quickly through the application and program design trade-offs, and maybe we have some time during discussion. We discussed with our stakeholders community health volunteer training, CHV incentives, and risk communication. And I'll just focus on training here and how we actually deliver the intervention. So our basic assumption was that CHVs need to have enough knowledge to deliver high quality services, but since they have normally a low level of education, a low level of digital literacy, and a low level of health knowledge, we opted for not confusing and overburdening them with technical details, like machine learning, which is complex to understand, or with details of the visit protocol. So we did not expose them to any of these finer details, and we communicated this in a way that we use standard WHO protocols and national Zanzibar protocols, what we are doing, but in a way that tries to optimize their work. So this is just one of the decisions, and we debated extensively, and it's a decision where we did our health system informed, best informed guess, but we are aware that we need to regularly monitor this. So to wrap up, machine learning is a technique with a lot of promise in public health settings. It's an emerging field and much is yet to be learned. So it is important to follow a responsible design approach, minimizing negative side effects, including the unanticipated ones, so including what some people call the unknown unknowns. Privacy and data protection is an important issue. It is something that gets more and more understood, and it is something that we can now discuss with different partners, because different partners, including government, understand it, but it is still something where we face open questions like data and model ownership, maintenance, and governance. A challenge that we face is that looking at scalability and ownership of these interventions, we need to think about maintenance of these techniques in low resource settings where, for example, government partners need to own the program. And then another really important topic where we are just at the beginning is the impact evaluation of these programs. So this is just the beginning. We have outcome and outcome evaluation, but impact evaluation is still something where we are in early stages, but it is something that we really need to put our focus on in the next years. And then, of course, we are seeing potential. We are seeing it is a promising technology, so we want to find other use cases where we can use this to improve the health systems where we are working in. So that's it for now. Thank you. Over to you, Chase, for discussion and Q&A.
Yes, thank you, Heiko. That was fantastic. I really enjoyed how you showed the responsibility that needs to go into a program like that.